This is the Barbell Therapy and Performance Podcast, where traditional healthcare is redefined to help listeners achieve peak performance, accelerate recovery, and elevate overall health. Hosted by Dr. Brett Scott, a doctor of physical therapy and national strength coach, this podcast explores the worlds of fitness, alternative medicine, and holistic health. Each episode uncovers innovative strategies and practical solutions for those seeking to enhance their quality of life when conventional methods fall short. It is our firm belief that every living thing has potential, and it is our mission to help you find that potential.
Right, everybody, welcome back to another episode of the Barbell Therapy Podcast. I'm your host, Dr. Brett Scott. With me here today is Dr. Ziad Dahdul, and he is a physical therapist who really specializes in ACL prevention, ACL reconstructions, prehab and rehab. He's a physical therapist, orthopedic clinical specialist. He's certified under the SFMA as well, and similar to me too, he is a functional range conditioning mobility specialist as well. And one quick ask for all of you out there that are listening, 84% of you won't like, rate, or review this podcast. If you could, please do so we can continue to grow the audience and get bigger and bigger guests on and continue to spread the wealth of knowledge that we like to offer to you guys. So, waiting no further, thank you for coming on, Ziad. And really, what got you into working and specializing with ACL tears in such a
No, man, I appreciate you.
niche?
I appreciate you having me, man. Honestly, it was a population I started working with. I've been a PT for 15 years now, so it was a population I started working with probably like my fourth or fifth year in practice, and started to see like the recurrence of people having their second tear, or they have like a meniscus issue on top of their previous ACL issue, and it just got to a point where I started seeing kind of the same stories over and over again, and I felt like it was a very underserved population. They were getting the bare minimum, but a lot of these high level athletes were not getting back to being high level athletes again. And so it kind of got me like down a rabbit hole as far as like how can we be better at minimizing re-tear rates and kind of getting them to be able to have it. If they're going to tear their ACL once, want to make it so that it only happens once, and why is it happening so often? And it kind of became like a passion project of mine, and I sort of just kind of ran with it from there.
Yeah, and before I forget to point out, Ziad has one of the coolest Instagram pages as far as like exercises go and everything. So check out his Instagram at Ignite Physio. You spell it with a Z too, right? Yeah.
Of course.
PHYZIO. So he's got a ton of followers. He puts out a ton of good content, and well, he's even an inspiration for me in coming up with new exercise ideas. But yeah, one of the biggest things is how do we prevent ACL tears in the first place? Because I've seen a lot and heard a lot too with like the turf that they're using now and the cleats, and they still haven't developed a great cleat for it. And then just from a training standpoint too. So what things do we need to consider there to not have this happen in the first
Yeah.
place?
Yeah, we try to frame in people's minds that like because the term prevention is very much a misnomer. Like I think people think that they can prevent it from happening, and it's like there's only so much we can do to reduce the risk of it happening. But like at the end of the day, what we're finding, it's happening a lot with 14-year-olds to somewhere around like the early 20s, so like adolescents up till college athletics, and a lot of times, especially with women more than men, a lot of times they're just not getting loaded enough at younger ages, and their strength and conditioning training age is so low by the time they go through the rehab process that you're like, we missed this somewhere. Like she should have been doing this stuff prior to doing these cutting, change of direction sports, and people are just not getting loaded and dosed appropriately at the younger levels. And I feel like that's the number one place we can have a really profound effect is like if we as physical therapists can get in front of a captive audience at a younger age and be able to put programs in place that actually just emphasize strength and conditioning and getting people really strong, and then just working on moving really well. We also forget that as kids are like in that adolescent youth phase, they don't even know their bodies at that point. Like they're still growing and changing. They got a lot of things going on at that point in their lives. Like they're not going to be the best movers in the world. And if we can do something to kind of help them be stronger and just move better as a whole, that would be just an absolute game changer when it comes to the frequency of like the tears happening at these younger ages. And I think like you talk about cleats and turf, playing on natural grass is always going to be better than playing on turf. We have enough data at this point to know that turf is contributing in some capacity. I think people treat it like the boogeyman. and it's not the boogeyman like the way we think it is, but it is contributing to a higher incidence of it. And you're right about the cleat part of it. Like they really just have not come out with something that allows people to be able to play on turf and be forgiving enough to let them change direction, but also have enough traction to kind of gain that, to have that stability. Nike just came out with a cleat. I think it's called the Vapor or the Viper. I can't remember the exact name, but it has like the front of the shoe has a circular pattern on the cleat instead of it being across. And their thought process is to be able to like plant that foot down and have the cleat sort of turn in the grass instead of it like getting caught stuck going forward while your body goes inward. And so there's some promising potential of that, but like that just came out like last year, and it's actually super cost prohibitive because it's like $350, and a lot of people are not going to spend $350 on a pair of cleats. And so I have a couple of athletes, soccer players that are using it, so I'm kind of curious to see if it gains any traction at all.
What's an ACL tear cost?
I mean, that's true. That's true. I mean,
Uh,
if it were me and it had enough like efficacy behind it, I'd be on it in a heartbeat because we know how much time and money it costs to tear your ACL for sure.
yeah, it's just funny to me too. We see so many doctors, physicians, even just people being like, "Oh, kids shouldn't be in the weight room. They shouldn't be lifting heavy weights, this and that." Yet we complain that kids aren't going outside all the time and that kids are just sitting playing video games. And it's like, no, they can be in the gym because these are the things they need to learn how to move their body, get stronger, adapt to load, get stronger tendons and all that, and not end up tearing their ACL.
Well, and
Like,
just think of it. You're 100% right. Like, just think of it from the standpoint of go watch kids at a playground. Like, they're jumping off things
you're
and landing,
loading.
and like you're loading a ton. And so, like, and really, what is heavy load? What's heavy weight for a kid? And like, they're putting way more load and demands on their body when they go out and play and at the playground and stuff when they jump and move around than we can by putting a barbell on their back or weights in their hands. Like, we're never going to be able to load it more than they can handle at that point, anyways.
I think if we look at this from like a super simple standpoint, because I think parents need to understand this too, because parents are still, regardless of what we tell them, they're still going to be skeptical.
Mm-hmm.
Is load is force, and force is mass times acceleration. So, and we see kids like work out till failure all the time. Like you do the monkey bars, you don't just go halfway because you got to a 7 out of 10 RPE and quit. Like you go till failure and then you jump off. Um, but any type of jumping, that's your body weight in mass times acceleration. That's a lot of load versus we're not accelerating nearly that fast typically when we put a barbell, in a front squat or a back squat or a deadlift or anything like that. Like there's a lot of force that kids do. Running is 4 to 8 times your body weight. So there's a ton of accumulated load. Probably, I don't know, if you do like a mile run even, it's probably way more than you're going to accumulate from a full workout with as much weight as you could use.
I think a lot of uninformed people tend to think that if kids end up in a weight room that we're putting 500 pounds on their back and asking them to do like a 1 rep max on a squat, it's like you don't even need that. You don't need anything near that in order to create a change. And but to your point, we try our best when we get a lot of our youth athletes. It's almost like a non-negotiable for like the minors for their parents to be here because like not only from a legality standpoint, but just from the standpoint of like the kid can understand all we want, but if the parents don't get it, they're the ones that are driving them to these places and helping them get there. And if they're not, and if the logistics aren't covered, these kids are never going to have access to this stuff anyways. And so we always want to make sure we try to inform people as much as possible, and and it starts with the parents.
Yeah. And another thing too, so I've had some younger people in their 20s and things with considerations. Do you think you need your ACL?
I think it gets back to like what is it that you're doing and what are the demands that you're trying to place on your body because the non-op ACL rehab world is gaining a lot of popularity in these last like 5 years or so, and so I've probably had maybe like 7 to 8 people over the last couple of years that have come to us and have wanted to opt to go the non-surgical route, and very very small sample size, but we've had people from as young as teens and 20s is tough. If they're going to play cutting sports, it's possible, but it's very difficult to get back to being able
Yeah.
to play cutting sport. But like, if we're talking about somebody in their late 20s, early 30s, weekend warrior type, not really playing high competitive level anymore, but wants to move and just be active, and then all the way up to 40, 50, and 60. We always advise them, like, if you want to avoid the surgery, give it a solid 3 months. And if you're not having any buckling, if you're not having any giving out, if you're not having any bouts of instability, and you're not having pain with like deep end range knee flexion, you're not having pain with like heavy loading, then that's a good candidate to try at least 2 or 3 months of non-surgical rehab and see if you can kind of get to a point, and then we just keep plugging away at it until either they start to have some issues or they just continue to go and they're like, hey, are you happy with where you're at this point? And then if you are, then you just knock it out and you fucking go for it.
Yeah, I've always told, I've had a few non-op ACLs recently, people that didn't want to have surgery, and both of them went to the surgeon who, after their first eval, like right after doing it, was like, yeah, you need surgery on this. But the surgeon didn't even take the time to ask what quality of life they want to live, what their activity level was going to be, and all that. And so when we sat down and talked about it and looked at what they have for range and everything else, like they didn't need the surgery for what they wanted to do, and they had full range of motion. They weren't really having any pain. They weren't really having any swelling left. They had terminal knee extension. It's like, you know, worst case scenario is we try this for 3 to 6 months and you don't get better. You can still go have the surgery versus just having the surgery, because surgery itself, just because you have a fixed ACL doesn't mean there's not things that come down the line with that. So I think that's the next point to make here too, is what comes from that. Because like one kid I just had, he's a police officer, and we couldn't tell at first if he had like a knee strain, and he just irritated the joint capsule a little bit, and he got much better within the first 2 weeks, but he's still having some swelling and stuff. And we're like, all right, like let's just go see what happens with an MRI. And everything was torn, full ACL rupture, full meniscus, bucket handle tear, and an MCL tear. But even that, I went to the surgeon with him, and the surgeon's like, yeah, if you're like functional and everything, like this is the first surgeon that agreed like surgery probably wasn't the best option for now and give it some time. But I think that's the next thing is what long-term issues do people need to consider when it comes to choosing to have an ACL surgery?
Yeah, I think the quality of the joint itself is going to play a large role in this. So, like, if there are instances of like instability and they are giving way and having issues there, you start to run the risk of like overloading your cartilage a little bit too much, and then you have kind of like degradation and like OA that kind of comes on a little sooner. You can actually take like an ACL tear and turn it into a meniscus tear because of all the rotational forces if you're still doing a lot of those rotational type things. But a lot of it like comes down to, are you preparing yourself for these things that you're trying to get back to? So like if you are doing things the right way, you still may end up having to have knee surgery or have to do a reconstruction at a certain point. But if you're jumping back into high level activities and you haven't prepared your body for those demands after the injury, that's where people tend to run into the problems. It's not the person that like, I tore my ACL and then I'm just living my life and going up and down the stairs and picking things up off the ground, stuff like that. Those aren't the people that are going to have the long-term issues unless they're just not preparing their bodies for even that level of demand. But that's what it all comes down to. Are you preparing yourself for whatever it is that you're going to get back to? And if you are, the chances of having long-term issues, like we talked about, are not going to be as high as it is with somebody who's either doing too much or not preparing their body for it.
Mm-hmm. And then when people do choose to have surgery, what considerations do they need to make long term? Because we do see some people have complications even 10, 15, 20 years later of arthritis kicking up, the need for a knee replacement, just surgery not getting them back to where they thought it was going to athletically. So, what are your thoughts there?
Yeah, I think it starts with graft choice, and again, getting back to the demands. Like, so I use myself as an example all the time. I'm 42. I don't play anything super competitive anymore, but I still want to go out and be able to play basketball and do all those things. We know that patellar tendon is still the kind of the gold standard in this. I would not have a patellar tendon graft if I went that route. I would actually just get a cadaver at this point, because I'm not going to take my native tissue and like make my quad significantly weaker for no reason, because I'm not putting the demands enough on it to be able to worry about re-tear rates at that point. So that's the example I use all the time. It's like you got to choose the right graft for the right person. If I had somebody that was already deficient in hamstring strength, I'm not going to have them choose a hamstring graft. Like, it makes zero sense to go that route. If somebody has open growth plates, you're not going to go with the patellar tendon graft because they are taking pieces of bone with it out of your patella. Like, a lot of those things are going to factor into the decision making process. But I think like if people would really take a step back and like just do a little bit of research, talk to a couple of surgeons. I always tell people you should probably not just talk to one surgeon. You should probably talk to multiple surgeons. The same way you should just not talk to one physical therapist if they don't feel like they're the right. If you're not 1,000% sold on the answers that you got, you should do as many different, do as much due diligence as possible to ask the right questions because you want to have somebody that understands what you're trying to get back to. But I think graft choice is a massive, massive decision, and it's a big part of it. And I think people just automatically think I have to have a patellar tendon or a quad tendon. But I think for older populations, the cadaver graft can be the right way to go.
Hmm. And so, what about for the youth populations? What's better?
Yeah, I think what we know about re-tear rates at this point is the patellar tendon graft is still the gold standard as far as re-tear rates and kind of like the ability to return to the level that they were at prior to the ACL tear. I mean, we're still not great at even getting people back to where they were before the tear, but like the patellar tendon probably gives them the best chance. Quad tendons are actually very, very highly chosen now. I'm not like it's not my favorite. I like the patellar tendon a lot more still based on re-tear rates and like just anecdotally based on how many issues people are having with knee flexion issues and quad issues with the quad tendon graft. I just feel like it's a lot harder to get the quad back after a quad tendon than it is after a patellar tendon. It just seems so much easier if you load the patellar tendon right. It's a much easier way to get the quad back than the quad tendon is. It's just it's a big sticking point for us right now because we're seeing so many more quad tendons now. And then like down the list is the hamstring graft. Like I wouldn't even touch a hamstring graft at this point.
Really?
Yeah, I mean because the hamstring is a secondary stabilizer for the tibia for the ACL.
Yeah.
So
So,
if you
why are we taking that away from?
and if you think about it, who are our people that tend to tear their ACLs the most? It's the people that are like super quad dominant, don't have a lot of strength in their posterior chain, can't decelerate with the posterior side of their body, and then we're going to take something that's already weak and then make it even weaker. So that just makes
Yeah.
zero sense to me. So like I hardly ever advise somebody. I shouldn't say never, but I hardly ever advise somebody to go hamstring graft unless they've got like beat up tendinosis on like their quad tendon or their patellar tendon, and maybe they're not a viable candidate for it. Like I just think that there's no reason to go with the hamstring otherwise.
Yeah. Yeah, that makes sense too, because then you're also, yeah, you're taking away from what already needs work to put it in something that's already been faulty on you. So, yeah, it doesn't really logically even make that much sense when you say it that way. Um, what about for, I don't know if you guys, you're in Southern California more so, but what about ACLs for skiers, especially like, yeah, your 25 plus year old people that want to ski and tore their ACL, but functionally they're fine.
Yeah, I mean, I've had some people that have gone back without having had the surgery, but again, you think about all those forces of going downhill and having to you better just beat the shit up out of your quads if you're going to end up getting back to doing something like that because like skiing
Hmm.
is tough from a gravitational force standpoint. And so when you think about getting back to skiing, I don't think it's a necessary that you have to 1000% go have the surgery if it's something that you want. If you're trying to be like just more recreational and just have fun with it. But skiers, I mean, we see how often these happen in skiers. That rotational force that happens when they're trying to turn and change directions and things like that. I mean, people don't look at skiing as a change direction sport, but it 1000% is. And you still
Hmm.
have to be able to apply the same principles to it that you would somebody who's playing soccer or basketball. It's just different because your feet are fixed on something and you're moving this like long lever as opposed to it being your feet. So I think the skiing population, I kind of treat it the same way that I would treat anybody else. There's a lot of 40, 50-year olds that get back to skiing and snowboarding and they have no problems and they don't have the surgery.
Yeah.
But there are some people that still want to get back to being going on like higher slopes and different types of slaloms and different types of intensity and demands, and they probably are going to need it if they're having buckling and giving out.
Do you find too that just people that are generally stiffer, like through their entire lower extremity, do better without the ACL than people that are more lax and mobile?
Yeah, I'd say like the one caveat to that, I would agree with that for the most part. The one caveat to me would be the ankles. I think like a lack of ankle dorsiflexion when it comes to like progressing that shin forward. If they can't get that ankle mobility to come back when they're trying to go non-operative, or they're just somebody that just has a hard time getting knee over toes. You think about how many things you have to do with skiing and sport and going up and down the stairs, getting up and down off of a low chair. You have to be able to get your knees to go forward. And the ankle is a big place that puts a lot of stress on the knee, both from a pain standpoint, and then I find that they just have a harder time controlling the movement. And so there's a feeling of instability because they can't control the movement as they progress the shin forward as they do those movements.
Yeah. And so looking at all these things, so kind of mentioning the ankle dorsiflexion and being able to, yeah, bend your knees forward essentially in like a squat pattern. One of the biggest issues we see in our clinic and with people is return to play coming up too soon. So what is what do you see the data suggesting now? And like my thing is, we do psychological. What do you live under an airport? It's like
We work right by a fucking airport is what we
okay,
do.
okay. Um, anyways, we're trying to do, testing on single leg jump strength and hamstring versus quad strength and making sure all these things are in line or they're in a safe ratio and psychological readiness as well. And then people go to the doctors and the surgeon will do like a, quad knee extension, knee flexion test and be like, yeah, you're good for sport. It's like, whoa, wait a second. So that's our big thing here that I try to drill parents with is because I think that the stat still is too that 1 out of 4 people will re-tear their ACL within the first 2 years post surgery, right?
I think it's either the same side or the opposite side. It's like somewhere around like 18 to 22% or something like that.
Yeah. Um, and it's like I put it to one person one way. I was like, all right, this dad really wanted his kid to get back to sport, and I was like, all right. I was like, well, if we're in a plane and there's 4 parachutes and we have to jump, and one of these doesn't have a parachute, are you gonna jump? And he's like, no. I was like, well, those are the same odds. So not going to play too soon because what are we finding now? Because it used to be 9 months, everyone was kind of clear to play. What are you clinically trying to educate people on now in that sense?
Well, I think like barrier number one is that time is a factor, but time is not the most important factor. And so, like helping them understand that, like, yeah, the research is pretty conclusive. If you wait past 9 months, the chances of a re-tear happening go down pretty considerably after 9 months. It's like it kind of flattens out, and it's not that big of a difference between like 10 months and like 13 months. So it's not a massive difference.
Yeah,
But educating people on the fact that time is one aspect of our decision making process, but it doesn't overcome the data. And so they have to be able to show that they have the limb symmetry is in a good place. So we typically shoot for 95% limb symmetry or more when it comes to quads relative to each side and hamstrings relative to each side. We also tend to shoot for, I think one thing that is underused is force output as a relative factor of their body weight. So we've had a lot of people that are like, yeah, your symmetry is great. You're like 95% on your quads and hammies. You're fantastic. But you weigh 200 pounds and your quads force output is like 89 pounds. And I'm like, that if you just think about it from basic terms of like, you're pumping out 89 pounds, but your body weight is 200. I'm not going to look at that person, even though they're symmetric, quote unquote. But I don't think that person is ready to get back to demands. Like you said, running by itself is 4 to 8 times your body weight. So I can't in good conscience clear somebody to get back to sport when they're not able to force produce as much as they should. And so that's another place that I think needs to be addressed more often is like looking at force output relative to body weight and then being able to look at quad to hamstring symmetry and ratio. So
how are you testing rate of force development?
it's a multitude of things. So we'll do like a torque calculation based off of their because we know obviously we don't have the luxury of having biodex or having access to that. They're just fucking expensive, so we can't have one. But we use like our isometric testing of the quads and hammies, and then we'll use like a torque calculation by looking at the moment arm of their shin and try to calculate that. We also use the flywheel devices, so we use the eccentric, and
Okay.
we'll get them on a leg X and a leg flex, and to be able to see what their force production or what their eccentric overload looks like and how well that they can absorb eccentrically on there. And then we use force plates to be able to get an idea of what their RSI is. And we try to
Yeah,
put all those pieces together as much as we can. It's a little bit, it can be a lot because there's a lot of things we have to test, but we feel like it gives us the best athletic profile kind of with what's available to us.
for sure. And it's always funny to me too. I actually saw a meme the other day. It was like it was someone at a surgeon and it was like, yeah, don't use the leg extension machine. It's too much force on your knee. But let's clear you go back to sport. Or yeah, you can go play again. It's like I think that data is old. We should be loading tendons. Even I learned in school they were like, yeah, don't put an ACL patient on a leg extension machine.
Yeah.
So what's
I learned the same thing too.
yeah,
But, but I think one of the things too is like, they look at it from the standpoint of like, hey, let's not put them on the leg extension machine because it's too much force. But also, um, here's the manual muscle test of your quads. Yeah, you're good. So that's enough force for me to test whether you're ready to for sport. But a quad extension is too much for a person. Like it makes the correlation is not there. It makes fucking zero sense that you would use an MMT to make a decision making process, but like can't put them on a leg extension machine. Like how else are you going to isolate the quads the way we need to?
And like that's good enough, but don't get it any stronger.
Exactly. Like it makes zero fucking sense. The other piece that's funny that we're talking about this. The other piece that's funny to me is like people will always say, "Oh yeah, don't worry about your non-surgical side. Just worry about getting your surgical side strong." And so I've talked to people like 3-4 months post-op, and I'm like, "What are you doing for your opposite side?" Oh, well, I haven't done anything. When I go to PT, and all they do is just the stuff that I do for my ACL side, and I'm like, so we're going to deliberately make your other side weaker as well too, so that when you get back to sport, you're overall a much weaker person, not just on the side you had your surgery on. That's fucking great.
Yeah. Yeah, not great. Is there any way you could kill that music in the background?
Is it a little too loud?
Yeah, a little bit.
Let me move spots real quick.
You're good.
I just turned on all of a sudden. The perils of being in a fucking gym.
Yeah, I hear you. I hear it all day. That's why I do these from my office.
Is that better?
Yeah, it's quiet now.
All right, let's go here.
Um, so yeah, so the leg extension and all that is just kind of silly nonsense at this point. And what about the psychological readiness though of someone? I've seen a lot more literature coming out and being talked about. That's one of the top predictors too of negative occurrences happening after going back to sport is they weren't psychologically ready to in the first place.
Yeah, I think addressing it is number one. I mean, like the confidence is probably one of the most important attributes a person has to get back. So, like we use the ACL RSI for a lot of our readiness testing. That's a big piece of it. And the two people that are like the scariest to me are the people that are super strong but have zero confidence and just can't seem to get over the psychological part of things. That's like number one. That's a hard one to get back. But the scariest person is the overconfident person that doesn't have the numbers to back it up. They kill the RSI and they're like 7 months post op and they're just like all the numbers are 100. I feel confident. I'm comfortable. I'm ready to go. And then we look at their numbers and their numbers are just nowhere near where they need to be. That person scares the shit out of me because that person is so fucking confident in what they can do, but we know that the data is not there to back it up. So that's the person you got to kind of rein in on. But that's how we're able to identify like confidence levels are super important. So we have a lot of conversations with people, and we're able to kind of work on helping them gain more confidence by showing them that they're stronger than they actually give themselves credit for. And the more prepared they are, the more likely they're going to be confident going into it. You have to be able to put them in as many situations as possible that are relative to what they're trying to get back to. And if you can show them in a controlled environment, they're going to be a lot more confident once you get back to kind of releasing them to sport.
For sure. And then you are now offering an online ACL rehab membership. What would coaching program? What would you call it?
Yeah, it's an all. Basically, we have a one-on-one online thing where we actually like do like one-on-one assessments with them, and then kind of draw up like an individualized program for them. And then we also have more stage-specific online programming that they can kind of add as a supplement to whatever it is that they're doing in their rehab process.
Mm-hmm. So is this something? Is an ACL rehab something someone could think is feasible to do completely remotely in telehealth, or should someone still go see a PT for the first few months to get their range and everything back?
So we're big proponents of them seeing somebody like us remotely or in person, but also going somewhere in network to help them save some cost and some money, but allowing somebody like us to be able to kind of be their quarterback on the exercise side of things. Like PTs
Mm-hmm.
are just shitty at dosing people. We don't load people well. And I know the early stages, people tend to look at it like it's super easy. It's not as easy as you think it is because a lot of times they don't even get their full hyperextension back. They don't get all of the range of motion back. And then we see somebody 4 months post op when they're finally ready to come in to do this stuff, and they haven't even checked off the low level boxes yet. And so we like to encourage people like, hey, go in network and like use your insurance and like that it's your benefit. You should go use it. But like let us at least have the control over your exercise part of things so we can make sure you're being dosed appropriately and then let you have the guidance. Because like people don't have any guidance when it comes to this. They're not told like what to expect, where you're going to go next, what's the next milestone, what are we shooting for, and we tend to serve as a big guidance point for them too, and help be kind of almost like the leader of this entire process. But we all work collaboratively together to kind of get the person back.
I'm curious how that works. So you're working with other people's PTs, taking them through the rehab
Hmm.
process without having seen them in person.
Without having seen them in person. So we'll basically give them an idea of like what. So they'll kind of we'll do like updated, like if we're doing a one-on-one with somebody, for example, like we'll look at it's not hard to look at range of motion and you get a feel of like quad activation. Do you still have effusion? Like how well does your squat look? Like how well do your patterns look? I can do all of that through Zoom. I don't need to put my hands on, but I can't manually manipulate somebody's knee to be able to gain, like, so if we see somebody that has a 15-degree deficit in extension or flexion, that's where we would say, hey, look, this person is still not quite where they need to be when it comes to the range of motion. Can you work on addressing that kind of stuff? Here's what we're seeing. What are you seeing? And then we kind of put a program together based off of everybody's thought process as far as how they're coming along.
Hmm. Do you ever run into trouble with PTs that are afraid to load people?
I run into too much of that. That's the most common thing we see is they underload them when it comes to the strength and conditioning side, but want them to get back to jumping really quickly and running. And that's usually our biggest issue is they get back to running and jumping way too fast, and they haven't even been loaded appropriately to be ready for running and jumping.
Hmm. Yep. Um, so yeah, where do most people go wrong with the rehab? Where do most PTs go wrong go wrong in the rehab process? And what should people be looking out for if it's themselves that are going through the rehab process with the PT?
Yeah, I mean, if your PT is not in some capacity assessing where you're at from a data standpoint, like not measuring your strength, not measuring things as a whole. You don't need all the fancy equipment to measure something. They should be measuring what can you do a single leg squat, double leg squat, like how there's a lot of ways that you can use weights to manipulate somebody's strength to be able to test how strong they are. But like if you're not assessing, if you go to a PT, like if I'm talking to somebody who had an ACL reconstruction, they're going to PT. If they're never measuring you, if they're never assessing where you're at, if there's none of that happening, you're never going to know whether you're ready to get back to something. And you're just like your parachute analogy. You're just hoping that you have a parachute in your backpack at that point if you're not assessing these things. That's the number one thing is that things don't get tested, and you're just kind of it's a wing and a prayer, and you're hoping to hell that it works out for you. The second piece that a lot of PTs miss, they don't do the foundations well. Like they don't do the boring stuff really well. Doing goblet squats and RDLs and all the strength stuff that we know is tried and true and tested. That stuff matters at the beginning. You have to do a lot of that before you can. I tell a lot of our ACLers like you have to earn the right to jump and run. You're not just given that right when you hit 3 or 4 months. You have to earn that right. And so, like a lot of times, a lot of PTs they don't load them well enough to get them ready for the jumping, the running, the higher, the fun stuff that the people want to see on Instagram. That's the stuff that you have to earn the right to be able to do. You can't just go do that shit.
How soon post-op do you typically end up having people do squats and deadlifts and things? Or and lunges, that's a big one.
Yeah, I would say the double leg stuff is it's almost always within the first month, so long as they're progressing well. The single leg stuff is usually like month two to month, like beginning of month three, somewhere in that ballpark. But somewhere in month two is usually pretty common.
Yeah.
Again, it depends on where they're at and what we're working on. But yeah, I mean that's very common for us.
And will you still, so say you're a month out and you want to start squatting someone, will you load them still even if they have like an asymmetrical pattern and they have a bias towards like the non-involved leg?
Yeah, I mean, I think a lot of times people's inability to load is it's hard to break through in the early stages, and you have to kind of manipulate positions. But I think a lot of people will just avoid it altogether, as opposed to saying, "Well, I can still load you through this range of motion, and where you're not doing any asymmetrical patterns. I'm going to load you there because you're tolerating that well, but I may not load you super heavy." When you get into your asymmetrical pattern, so we're going to work on that, but we're going to load you otherwise in the ranges of motion that you can control.
Mm.
That's a big thing that I think a lot of people miss is they think like, oh, I have to have full range of motion before I can go do any loading. It's like, no, you don't. You can do partial range stuff before you have your full range stuff and still be okay.
Yeah, that and like the whole like we work with a lot of trainers and stuff too, and for some reason trainers think they need to move perfectly, and like they can be the biggest head cases of patients sometimes. Sorry, trainers, but um, it's and then there's even some PTs like, well, we can't load that because it's asymmetrical, and it's like, well, yeah, they just had their ACL tear, but like, is it better to avoid it completely or expose them to it so that they can start building some confidence in it early on?
Yeah, 100%. And I think they'll also make that judgment after watching somebody do a certain movement like once or twice when you're not realizing that this is their first or second time doing that movement since their surgery. So I can't even expect them, even if they felt great. It's really hard for me to expect somebody to do like a squat really well after an ACL reconstruction because they haven't done it since their surgery. Like give them a set or two to kind of get a feel for it. And if you can't cue your way out of the asymmetry, then change the range of motion and then go work on that asymmetry, but load them in a range of motion they can tolerate.
Yeah. I think the other thing too, people have no idea how brutal surgery is and what the leg just went through, even a month out. It's like, yeah, you have a new ACL, but it's still healing. Like I posted a video yesterday on my story. I don't know if we're personal friends on Instagram, but it was someone removing an intramedullary rod from a tibia and like literally using a sledgehammer to get it out. And so many people messaged me like, "This can't be real." I was like, "No, that's real." Like, read the
That's
comments.
really,
Like,
yeah.
this is from a surgeon's office that like posted this. Like, this is what they're doing, and they're like, "No, I can't. Like, I'm gonna be sick." I'm like, "Yeah, well, maybe you want to think twice about having the unnecessary surgery if it's unnecessary." But
Well, what I tell people a lot, it's funny that you say that. Like a lot of times people will say, "Well, I had the surgery, so shouldn't I be fixed now?" And I'm like, I'm going to play this video for you of somebody getting a knee replacement. I want you to just close your eyes and listen to the video. You're going to think somebody's working on a car. That's what it sounds like. It sounds like they're working on a car. They're not working on a car. Those are all the tools that they use in order to put that new hardware in your knee. So like the
yeah,
fact that you're still sore 2 weeks after your total knee, there's a fucking reason for it. It's because they beat the shit out of your leg.
I had a patient a while ago, and I don't think I've told this story on the podcast yet, but yeah, he was probably in his 50s, tough guy, and he was like, oh, he had the knee replacement. He's like, oh, I think I bit off more than I could chew, this and that. I don't know why I did this. Like, it should be better now. This is supposed to be a new knee. And he's like, why does it still hurt? I was like, well, it might be a new knee. However, they went in there and they cut you wide open from like your femur to your tibia. Then they took a saw and sawed off the top of your femur and the top of your tibia. And then they took a drill and drilled into your femur and your tibia. Then they took a sledgehammer and drilled these pieces of metal into you with concrete while you're on a distraction table and then sealed you up together. I go, that sounds pretty traumatic, right? And he's like, well, when you put it that way, yeah. And then one of my other PTs was around the corner. He's like looking at me. He's like that. He's like, you are brutal. I was like, well, that's what they do. That's just
Well,
reality.
it's the fucking reality of the situation. What else are you supposed to do?
I don't sugarcoat it. So yeah, I was like, sorry, but then it's like, well, and that guy came back with a completely different perspective. I'm like, okay, I guess pain is expected now. It's like, yeah, dude, you're
Can
still
you do
healing.
all of us a favor? The next time you have that conversation with somebody, can you have somebody behind you recording their reaction to you
Yeah,
saying these things? Because I would fucking love to see their face when you're saying this.
I'm gonna put this. I'll try to clip this actual segment and put it up on social media too. It might get a lot of plays. Um, and as far as return to play, there's some big pieces there too that I think PTs go wrong with. Of like, yeah, doing single leg hops in one direction back and forth, and then doing ladder drills and jumping over a 6-inch hurdle is not adequate for return to sport these days. But people go to
No,
these sports rehab clinics and it's all this bullshit. It's like, yeah, that's so old school that doesn't work, and we know it. And we shouldn't be doing that anymore.
yeah, and a lot of times it's like the sport specific things, and the first thing they bring out is a ladder, and I'm just like, no shitting on ladders, but like that's not it. Like doing ladder drills is not going to get you back to being able to cut and change direction. It's just not how it works. And that this is sort of like my bone to pick a lot of times with social media. It's like people will take things that they see on social media and just like have people do them as like a one off exercise here or there. But there is a linear thought process that goes on just taking somebody through this entire process. So once you get to a point, if I have somebody, for example, that's playing basketball, if I'm not having them jump aggressively from higher levels and putting a lot of load and demand on them, I'm missing the boat completely. It doesn't matter how good the rest of my stuff is. That's a jumping sport. I have to have them do high levels and high intensity jumping in order to get them ready for their sport. And that's what a lot of people aren't doing is they're not. Again, we get back to like dosing. We're going to keep talking about this over and over again. It's like it's all a matter of reverse engineering. You got to think about what does this person need to do? and let me walk my way back from where they're going to need to get to. And then I can start to figure out what I need to be like putting in front of this person and having them do when they're with me. If you're not doing that, then you're just really doing a disservice to the person in front of you, like plain and simple.
Yeah, and so, well, the ladder is an interesting one, right? So, do you still use the ladder in your rehab at
I
all?
use it for things that are not like I'll use it as a barometer for like where I want you to hop, but I'm not doing like speed drills on the ladder.
Yeah. Because we use it now for people like entry level into like this is the
Yeah.
very beginning stages of return to sport of like let's have you bounding in different directions and introducing some light plyometric movement and things. But at the end of the day, I think where people miss the boat a lot is like sports are very reactive. Like when you're on a ladder, you know where you're going. It's predictable. Versus sports, you don't know where the ball's going. You don't know where the next hit's coming from or when you're gonna need to change directions. You need to react to what's happening, which is a completely different demand on the body than being able to say, I'm gonna go left, I'm gonna go right, I'm gonna go left. Right?
And it's like you're saying, like that's a good place to start. You want to start with it being more planned and controlled, and then you have to add chaos in a controlled environment in order for them to get back to sport. Sport is they're making a million decisions every time they play a game. Every single thing they do is a decision they're making. They're not just but they're responding to their environment when they're making these decisions. And so, like I agree with you, ladders are a great way to just get somebody to move again, move quickly again, get confident again. But like you have to be able to incorporate as much reactive training as you can in the later stages of the recovery process.
Yeah, we try to do as much like game playing with people and getting them to read and react to us as PTs or like I see you guys use the blaze pods a lot, stuff like that,
Mm-hmm.
where it's like completely they have to guess and move from there, which can be very big for someone. And
Like shadow
then
drills, catching a ball, like that kind of stuff is the shadow drills are great too because that's about as close as it gets. Like I don't do it with, I won't have them do it with me because even when they're like 5 months post op, they'll still torch my ass. So it's I'm not as much enough of a challenge for them. But like if we have like our interns or if we have other athletes there, like we had this cool 2 weeks ago on a Friday, we got 6 of our ACLers together on a soccer field, and they were all like 8 to like 2 years post op, and we put them all in a field together. And we just had them do an hour's worth of soccer drills together because they're all going to be respectful of each other. And they know where they're coming from, but they didn't know each other well enough to know like how to defend each other and how to do things with them. It was the coolest fucking experience because it's 6 girls that all play high school soccer and they're all going through the ACL rehab process, and they all got to go out there and help each other get better at getting back to sport. So that was really a powerful like experience that we had a couple weeks ago.
that's really cool. Um uh I had a question there from that, but I don't know. It just went over my head. Um oh, yeah. So with um I know weightlifters, so just it's part of training and things like a training consideration for people. So Olympic weightlifters, as I'm one of them, are known to have some of the thickest, strongest ACLs um based on imaging we have of them. So and part of my thought process is like, well, what is it that's making that ACL strong? Is it that 25 degrees where it's on the most tension? And a lot of our work we do, like with power cleans, power snatches, the jerks, the bottom of that position is about 25 degrees of knee flexion. So, what considerations should people be putting into their training too for building a strong ACL that's less likely to tear?
Yeah, I think when you talk specifically about weightlifters, like if you think about the cleans and snatches and where you're catching the weight, like think about how much load you're adding and how high of an impact deceleration movement that is through a very small range of motion. Right. So it's like
Yeah.
it really is a high level deceleration with an external load on you, is what you're doing. So like in order to do that, like you have to really make sure like that's where like we get back to ankles. Your ankles are so important in that. Your ability, and I think another place that gets underappreciated is can your tibia rotate well? Like you think about being able to like unlock from external rotation into a little bit of internal rotation as you flex the knee. And if your tibia is really stiff and stuck or you're stuck in external rotation, that's another easy place to lose a lot of stability in the joint. So like I would say making sure you're grooving a lot of tibial internal rotation with flexion in addition to ankle dorsiflexion, and then even like thinking about like your rear foot with your ability to be able to like evert and move through your rear foot. Like that's such a big piece of it as well too. So like, but I think like looking at that lower chain, like the knee and below, and if your tibia can't move well, I think that's a big place where people are going to miss the boat on a lot of things. And I think obviously the hips are important, but like if we're talking about the higher range of knee flexion, I think the ankles and the tibia are probably more important than the hips are.
Yeah, so that's kind of a one of those things too. That's kind of I've seen a lot of tunes change over the years. Of everything used to be all about the hips with ACLs, and now it doesn't look like so much of that is the case anymore.
Well, I still think the hips are really important when it comes to like change of direction and the ability to be like your pelvis has to be very solid, very stable, very controlled when it comes to a lot of single leg tasks. But if we're talking about like a weightlifter, I don't think it's as important for somebody who's not doing an ass to grass type of thing, unless they're catching the body, the bottom of a clean and stuff like that. Like obviously you're going to go a little deeper with that. You talk about power cleans, but like that stuff matters, and I think the hips are important. It doesn't have to be in isolation. Like just because you're working more on the ankles doesn't mean you're not working on the hips. But I do think the ankles get less addressed. And I also think like a muscle like the soleus gets less addressed, like with how much it controls your shin going forward. Like that shit matters, and people don't work on that enough. They don't think about. They think about the gastroc, but they don't think about the soleus, or they think about, hey, maybe I'm focusing on the hips too much, and I'm not focusing on the ankles. Doesn't mean you stop working on the hips. It just means that you might need to put a little bit more attention in other areas, except for just the hips.
Yeah, it seems like the glutes used to get blamed a lot though for like the ACL
For
tear happening
everything.
in the first place, and
Yeah.
it's like it doesn't seem like that's the case anymore. It's just like we're just generally weak or uncoordinated or unstable, or we have poor movement patterns, or we just got hit and had no control over this incident if it was a
People
contact.
want answers. They want a
Yeah,
reason for why it happened. It's much easier for them to it's much easier for them to be able to accept what happens if they know why it happened. And for us to tell them that it depends and we don't know 100% why it happened, but these are the reasons we think, that's not as easy for people to understand. But if we say, hey, your glutes did it. Like fuck your glutes. That was the problem. Like that's people like to hear things like that instead.
yeah. So do you still do like the good old single leg or not single leg, but the banded monster walks and crab walks and all that stuff as part of your ACL rehab process?
The only time I would say that I use that now over the last like 5 years is as a warm up and a primer more than anything else. For the most
Yeah,
part, it's like beyond that, I don't really do any of that anymore. I don't think any of us really do.
yeah. So you're more focused on just total body single leg, getting towards single leg strengthening in larger patterns and compound movements versus these little old isolated clamshells and this and that. That's kind of
Well,
nonsense.
well, I still think like that. Something like that to me, it's like you can't load it heavy enough and have somebody do it well enough to be able to stimulate a change. It's just not going to happen if we're trying to get somebody stronger. But if you try to warm them up and have them feel something, then I'm cool with it. But like, I still think there's a time and a place for isolated strengthening. It just has to be isolated strengthening that you could dose appropriately to create a physiologic change to actually make somebody stronger. And it's just hard to do that when you're doing these compound like lateral movements like that. It just doesn't happen.
Yeah, absolutely. Well, I think you have to run shortly here, man. And I think that's a good place to stop for us today. Anything else you wanted to add, though?
No, I think like conversations like this are like super important because the more people, I think PTs, if they want to understand it, they will. If they don't, there's enough resources out there for them to figure out how to be better at these things. If they don't want to, they won't. But I think from if we start kind of we try to direct to the consumer as much as possible. Like I want the ACLer to understand what is supposed to be the norm now. I don't know. I almost don't care whether PTs understand it or not because if they want to, they would. If they don't want to, they're not going to. So like, but if the ACLer understands what the expectation should be, then they start asking the right questions, and maybe they start putting pressure on their PTs to be better at doing this shit because right now we're failing them as a whole. And so we need more people to understand how to do this better. And so like I want people to understand, like I like that you're doing a podcast where like you give this to a lot of your clients because if they understand it, they're going to start advising their friends and family. Their friends and family are going to start asking the right questions. And then all of a sudden, hopefully we have a grassroots change of this thing on the ground.
Yeah, absolutely. Because I think ACL is probably the most common injury too for youth athletes, right?
It's like the incidence is like 300 plus thousand a year now in this country. It's fucking
Wow.
wild. Yeah.
Is the incidence rate rising? I assume.
It's right. Yeah. It's 100%. It's like skyrocketing.
And is that just well? I think there's multiple things here. So much for ending. So it's probably the turf and shoes is one, But then what about just like general physical preparedness of our youth and like the obesity epidemic and rest
Yeah.
and stress and all that?
Well, I think you combine two things, right? So you combine not the kids are not as active as they used to be, so they're not out and about doing stuff that's just more like play, as opposed to all having to be very structured, like you're just practicing a sport. And then I think the specialization. I think kids are and parents are said, well, your kid's 8 years old and they're like an all-star. You should just have them play this sport, only this sport. And it's like, well, you're missing the boat because like they're not gonna get all of the things that you get from playing soccer and you learning how to use your feet, from being able to have hand-eye coordination by playing baseball or softball, by being able to jump and do things like playing volleyball and basketball. Like let these kids figure out how to just be athletes and not specialize. I think specialization and underloading are the two biggest reasons why this epidemic is occurring, and it's why it's happening in girls more than boys. Is because it's much more common for a boy in high school to do weight training than it is for a girl in high school to do weight training. And I think we're failing them because we're not allowing them to strength train at a younger age and just be used to doing all of that as they get older. So I think those two things, specialization and underloading, are the reason why this is rising, and it's going to keep going that way until we fix that problem.
Yep, because we see this with soccer, we see Tommy John with baseball, we see, all kinds of other things too in other sports, hips with hockey players. But literally, I've had like 3 strength coaches at the professional level on my podcast recently, and a couple of doctors and PTs. And literally everyone on here says we need to stop specializing so early, yet no one wants to do it.
Yeah,
Multi-sport
because
athletes are robust athletes, and they usually make it to a higher level. So I think, I forgot what team it was. It was like everyone on the team was a multi-sport athlete through high school.
yeah, I think the NFL they did a study on an NFL draft a couple of years back where they were looking in all the people in like the first like 5 rounds of the draft, how many of them played multiple sports in high school, and it was like 91% of them played multiple sports. They did not specialize in just football.
Yeah.
Like that, the data is there, the research is there. Just people are being told other things because there's a lot of money to be made on somebody specializing in one sport.
Yep. All these specialty teams and coaches and everything. Yeah.
Travel ball club teams, they make so much fucking money. It's disgusting.
Yeah. All right, man. Well, where can people, even though I kind of gave you a shout out already, where can people find you?
Yeah, like as far as like our content goes, like Instagram is kind of where we're the most active, and so it's the handle is Ignite Physio. If they ever want to hit us up like directly, like our website is ignitephysio.com. Like all of our PTs have contact information on there. So if anybody ever has any questions about any of this stuff, we just want to be a fucking resource for people, man. Like, so if we can point people in the right direction to do things better, whether it's with us or with somebody else, I'd rather them work with somebody else closer to them that's really good at what they do than just go to a run of the mill place and be failed in that way. So those are probably the 2 easiest ways to get a hold of us.
Yeah. And you're also doing a course now, or coming up with a course I saw for like PTs, coaches, rehab professionals, etc., on rehabbing ACLs as well. We'll give you a shameless plug here.
So we did our first one in June. It was called the Athletic ACL. So it's basically like a continuum from start to finish on like our philosophy and our approach and how we go about it. And we had orthopedic surgeons spoke. We had a bunch of PTs speak. It was like our whole team spoke. It was a great experience. And then we had like almost 40 PTs that showed up for this thing to like learn about this. So we're hopefully going to be doing like 2 of these. That plan is to do 2 of them next year and host them here. And then maybe we do something where we try to, have somebody else host us in other places as well too. But like, that's something that we want to do a lot more of because we feel like at least that's one way to help our profession just be better at handling these things.
Absolutely, man. Love what you're doing for the field. And yeah, it's a tough profession, but people like you are helping to change it, and that's all we can hope for. So if you guys have questions for Ziad or myself, or you can't find his contact information, feel free to reach out to us as well, and we'll put you in contact with him if need be. So thank you for coming on, man, and thank you guys for listening.
This is the Barbell Therapy and Performance Podcast, where traditional healthcare is redefined to help listeners achieve peak performance, accelerate recovery, and elevate overall health. Hosted by Dr. Brett Scott, a doctor of physical therapy and national strength coach, this podcast explores the worlds of fitness, alternative medicine, and holistic health. Each episode uncovers innovative strategies and practical solutions for those seeking to enhance their quality of life when conventional methods fall short. It is our firm belief that every living thing has potential, and it is our mission to help you find that potential.